I'm thrilled to be here tonight. Thank you for hosting. And also a huge thank you to our hosts, Tokiyama, Shofu, and Kanemak Denno. I'm sure you've all had a very busy day today and just really thrilled that you're here to chat with me for an hour about dentistry. I am, again, Dr. Priya Tirumalassetti. I am a 97 graduate of the University of Michigan School of Dentistry. I did a GPR right after school, and I'm an accredited member of the AACD, a COI Center graduate, and I recently got my mastership in the AGD this past summer. My hobbies include running, traveling, and photography. And it ties into my clinical dentistry because I absolutely love taking pictures. The pictures you'll see of the patients tonight are those that I took. So let's jump right into our topic, diagnostic wax-ups, digital or analog. We will go ahead and do a couple polls tonight just to see where you are as far as digital scanning or analog impressions. So I will stop in between probably about 4 times to take a poll. But what an amazing time to be a dentist. We have all these amazing innovations, scanners, printers, milling, CAD design. It's just so exciting to have all of this in our toolbox. Where are you in your digital journey? Are you actually doing analog impressions or scanning? Are you waxing up your cases yourself or digitally designing? Are you milling your own restorations and so have a full digital workflow? And have you started to use AI? There's just so much out there for us to choose from. So maybe this is a good time to poll and see where you're at with your journey. Are you digitally scanning in your office? Let's see what the results are. So far, it looks like half of you, about 53% of you are digitally scanning and 47% of you are not scanning. Perfect. All righty. So to me, a diagnostic wax up in general is just getting ready and prepared to do a case. It's about assessing my risk before I start, before I prep, communicating to both my ceramist and to the patient, and then just to review my data before I get started, just to kind of put it all together into one place so that I have a game plan and I could try to have a predictable outcome. So a few questions that I might ask before doing a wax up, because we might not always do a wax up. How many units are we doing? Is it a fully additive case, or are we subtracting? Are we prepping? Are we taking away? Would I like a ceramist or technician to help me plan this case? And does it make sense to do a diagnostic wax up that I'm outsourcing, given the fee that I'm going to charge the patient? And also, do I need it like right away? Do I need it today or tomorrow? Am I in a hurry? So because I think it's such a huge predictor of how I can plan this case, I always do a wax up for more than 2 units, especially in the anterior. And I'm able to sequence and treatment plan that with my ceramist and patient if I need. And then I can also see where I'm taking away and where I might be adding. So I just feel like it's a great tool for planning. Before I start doing a case, I try to formulate a checklist of all the things that I need. So first and foremost, as we all do, we acquire our data, we get everything that we need from the patient. We'll review all of this data with the patient and find out where they are with their goals. Run through the planes of the face, look at the canine at rest and determine the maxillary edge position. Look at the soft tissue, of course, and then get into the shade, the proportions, the shape, and alter the maxillary occlusal plane. So we'll break this down a little bit more. First, we start off with getting our health history, our dental history, take all of our pictures, and then we'll either scan or take an analog impression, take our CBCT possibly, or our radiographs, and then do the clinical exam that we normally do. And then again, we put this all together, review this data with the patient, and ask them what they want. Are they willing to do something bigger than just prepping on the teeth? Are we going to crown lengthen? Are we going to do some orthodontics, possibly Botox or lip repositioning or surgery to get to what they really want? And how much are they willing to invest in doing this? So we have that conversation with our patient. And then, of course, we take a photograph of the whole headshot and look at the planes of the face, look at all of the where the midline is, incisal plane, interpupillary line, and see if things are symmetric and harmonious. So if we look at a patient's photo, we start off right here, and we can see that we've got our facial midline right down the middle, incisal plane across here, and interpupillary line. So easy with just a headshot to be able to kind of draw lines on the picture to assess that. And then we move on to determining the maxillary edge position. Are we keeping the length of the incisors right where they need to be or right where they are, or are we changing them, lengthening them, or shortening them? So I start by doing that with looking at a rest position photo where I can see the patient in their relaxed kind of natural posture and measure where the canine length is. Most people on average have a 0 millimeter or what's called a cuspid 0 display when they're at rest. And that canine length should match the length of the central incisors. So that's my first guideline. And then of course I look at the length to width ratios and decide if I'm going to alter the gingival height or change the length. I'll run through and look at the lip dynamics. So we asked both of these patients to smile. The patient on the left smiled, and you can see how much gingival display that she has. The patient on the right barely has any. So different reasons for why that might be. Lip mobility is one huge part. Compensatory eruption due to wear, altered passive eruption, and then also vertical maxillary excess. So putting that all together, we look to see if we're going to keep the position of the gingiva, if we're happy with the symmetry and the scallop of the gingiva, or are we going to actually change that? It would be nice to have it all kind of beneath this blue line or at the blue line when we look at this little schematic. And then we can go into the microaesthetics, the embrasures, the contacts, dominance, inclination, and surface texture, color, golden proportions, if that's something that we use. So then we put together this checklist. So starting from the left, we look at our photos, touch upon the patient's goals, and then analyze if we're going to change the incisal edge position by looking at the canine, and then our soft tissue stuff. And then we can put the diagnostic wax up kind of in this box here before we alter the gingival margins. Sometimes if my periodontist is involved, she kind of has a plan and I'll do a wax up afterward. So, and then if we need to, certainly alter the occlusion in the maxillary plane. So putting all of this data together, we start to do our treatment plan. Before we had our scanner, we would just do an analog smile design, which many of you still do now, which dentists have done for years and years, and it works perfectly fine. So we start with our photos and our impressions. We sit with the patient, review their treatment goals, and then in the past, I would just kind of draw on the photos, show them where we could change things and where we would alter the gingival height. And then from there, devise our wax up and then compose a treatment plan. Lots of great things about doing things in an analog way. You can outsource the wax up or do it yourself. I think that I'm sure we've all at some point in our career have waxed before, whether it's in our practice or in dental school. And it's an amazing way to kind of learn the nuances of the case before we actually sit down to do our restoration, whatever that might be. And you can literally hold it physically in your hand and make the change easily. You could modify it. And it's a great communication tool. And that's how it's been done for many, many years. I prefer an analog wax up when I'm doing chairside composite veneers because I can build the lingual and palatal shelf, and I don't have to do a full contour wax up. I just wax up the edges and the lingual, and I use that to form my putty stent. So it's a great little tool. It doesn't take that long, and then I have kind of a precise measured out shell that I can use to build out my composite veneers. Also, if we're doing just a fully additive case, it's a great way to present that to the patient. And at the end of the day, wax is beautiful. So why not? But now again, we have all these tools that we have with the technology that's out there. We could do a digital wax up as well. And those of you who have scanners and are scanning might already be doing this, but we can do a digital wax up on our own, or we can outsource it to a CAD design outlet. And that way we can plan the case very precisely down to the tenths of a millimeter, which is amazing. And then we could modify that if we need to, decide where we're going to prep, where we're going to not prep, and have a really good understanding of whether it's going to be additive or reductive in certain areas. And all of that we can communicate both with the ceramist and with the patient. And once again, it's just a great way to envision our end goal. So which way should you do it and which is more cost effective? At the end of the day, you want to know how much you're able to charge the patient, because if you're spending the time and the money on doing a wax up, it really should be incorporated into your fee. And, years ago, we would always forget to charge for the wax up. And then if we're outsourcing that, that extra fee was just not accounted for. So if you're going to do your own wax up, do you value that as your time and incorporate that into your fee? And same for outsourcing it. So if you're paying, let's say you're paying $75 a unit, are you going to be able to put that into your final fee before you proceed with that? So you just kind of have to have an idea of how you do it. And of course, if you need it in a hurry, then that's always an issue too. So if you are a fee-for-service practice, all of this is a little bit easier because you can just set the fee and incorporate the wax up, and it works out pretty well, and just present that to the patient as one fee. If you are in a DSO or have a PPO fee schedule, it can be very limiting, as you might know already. And so how do you incorporate your time and or expense for having a wax up done? Can you wrap that into an additional lab fee and just let the patient know that we're going to do this and we have to do this as a roadmap, as a guide for the plan, and then just kind of incorporate that fee in that way? So coming back to diagnostic wax ups, you can do it analog, you can do it digital. When I personally am doing an additive case, when I know I'm just going to be adding onto it and not really prepping that much, I will certainly consider both ways. Either I do it or I outsource this. But at the end of the day, I would love to have a template, a putty stent, or some type of a template that would guide me through the treatment. So either way, I think is okay for an additive wax up. But how about if we're prepping? And most of the time when we're doing ceramic, we're trying to minimally prep or certainly prep. So with a reductive case or some type of combination case, I usually am doing multiple cases. And if I am going to spend hours waxing that time, it would be really hard to value that time. So I personally prefer to refer it out if I'm going to need a full wax up. And analog is not my personal first choice. I think a lot of people can do this beautifully and it's amazing. It's great. I just don't have that much time to spend in the lab. So with the reductive or combination case, I'll go ahead and do a digital wax up and then review where that needs to be reduced prior to prep day. And I know where I'm taking off. So for me, with a case that I'm prepping, I prefer to do a digital wax up. But if you, again, don't have a scanner and you're not really doing a lot of digital work, where do you actually start with this? It's kind of scary. Let's throw up our second poll. Are you doing your own digital wax ups or any kind of wax up really and outsourcing them? All righty, it looks like 73% of you are outsourcing your wax ups and 27% of you are doing these on your own. That's so interesting. So I love to get this feedback from you. In early 2020, we got our scanner. We have a Trios 4x3 shape scanner, and then we have a Formlabs digital printer that we also purchased at the same time. We began just doing smile previews and found it very, very useful just to engage and motivate the patient by showing them a preview of what they're doing. So we would, in the beginning, just draw on an iPad and use an Apple Pencil with Photoshop. And once we got our scanner, it came with an Excite app. It was called the Trios Excite app. And we were able to kind of just plug the pictures in. There are other sources that you can use, such as SmileFi or DSD or Smile Cloud, more of a subscription service that helps you to kind of plan and develop a treatment plan and a wax up. So let's actually look at a case. When we first got the scanner, we really just were comfortable doing kind of like a virtual smile preview. So here's the first one that we ever did. You can basically take a headshot and a retracted smile photo and plug that into the software, and it'll draw us these little lines, and we'll start to look at our planes, and we'll start to look at what smile libraries we might need. So this particular case, we ended up using the Matt Roberts smile library. There's many to choose from in the Excite app, but basically it'll preview how this treatment could possibly turn out for the patient. And you can do this in all of 10 minutes. So we took the pictures, plug it into the software, and she's ready to go. She loves how it looks. And even if she's not ready to go, she has an idea of what this can look like in the future. So after we did the smile preview, we pretty much went ahead, just did a fully analog case. We did a traditional wax up and then prepped and took analog impressions. Here's her before. And then on the right side, of course, is her after. And there's our close-up retracted view. And then for me, the very, very fun part, apart from doing the dentistry, of course, is to take photographs after we're done. We do these headshots in the office, and the patients really enjoy it, and we enjoy it. So every once in a while, we'll bring out a little fan and blow and get movement to the pictures, and it's just a whole lot of fun. So there's our very thrilled and happy patient. So what do we do for a ceramic case with full lab support? So if we kind of look, I know this is a very busy slide, but my workflow for a digital scan and photos starts with us sending all of that information to the ceramist, and then we review the history and determine if we're going to have to restore this in MIP or if we need to alter the occlusion. And then we fabricate our wax up. The ceramist is able to give us feedback on the thickness of where we're taking off and where we need to add. And then once we present this to the patient, he or she will approve it, and then they'll fabricate an analog model. So let's look at another case. So this is a case that we did actually start to finish with full support, and we were able to plan this case digitally. This patient presented, and she's been a patient for years in our office. She wanted to change her smile, of course, and just looking at this slide alone, you can see there's just a lot going on. Number 9 had trauma to it, and she wanted to change how that looked. But then we look at the gingival heights, and it's just not harmonious. There's not symmetry, and the centrals are more coronal to the gingival heights of the laterals and the canines. So lots going on there. And we start by scanning her and send the STL files off to the lab. Now, if you take a look at this, when we first started scanning, we would never trim our models. You can see all these really craggly edges, and our scans were kind of a hot mess. So now we always trim these scans before we do anything with them, because it's just a lot less work later on. So the ceramist starts off by taking all that data, plugging it into his or her software, and then we get a smile preview, much like what we saw before with the first case. And then we start to see our proposed wax ups fully digital. And this still doesn't make a whole lot of sense if you're just kind of looking at the wax up alone. But then he gives us a married model, a pre-op model combined with the post-op model. And then now you can start to see where the existing restorations kind of in that tan color are poking through the proposed wax up. So it's really neat to see this, and we could start to plan where we're going to prep away and where we can kind of add on to. So in this view, in this cross section of the canine here, you can see in black that's the new restoration, that's the finished restoration, and then in kind of the periwinkle is the existing architecture. And it's great to be able to see this, because you know that you'll prep from the outside of the design in, so you take that depth into account. We just kind of move across here, and he sends us all these images. We see the centrals here, the cross section. And then here's our canine again on the other side. We see some just kind of hard tissue kind of peeking out through that wax up. So Then he'll send us a summary, and we know that we want to alter the gingival heights here. We want to raise 8 and 9 and start to get our ratios in order, or ducks in a row. And then he'll send us everything that we need to prep the case. So these stents are just amazing. I'm sure you've worked with them, but the incisal clearance and then the labial clearance stent are there to guide you through your preparation. And then my favorite one is this mock-up and provisional stent. If you do a mock-up prior to prepping, this is fantastic. Of course, I'm sure you've used this. You put your provisional material in there, and then you prep down in and do your depth cuts from there. And then the same stent is used to do a provisional afterward. So here we are kind of working through the case, and she's on the left side, you see she's had her osseous recontouring, and 7 and 8 are in a much better position. And then we've prepped. And then here she is with her provisionals on. And then my favorite part, the photography. There's our after. There's our retracted lateral shot and our happy patient. So very helpful, and just a big plus to have that guidance from the ceramist and see everything prior to prep day. So I still love to take an analog impression, even with all this amazing digital technology, especially if I'm not breaking contacts. For a multi-unit case, I am a PVS person. Catapult makes a really nice impression material called Panacell Initial Contact Extra Light, and that's the wash material. And there's a Tray Soft, which is a heavy body material that kind of just drives that wash into the sulcus, and then you just get a really beautiful impression. So I still sometimes will do both. Haven't weaned myself off of the impression piece of it. I just think that impression comes out so nice. Catapult also makes a fantastic bite material with really great shore hardness called food tar that I use to take my bite. It doesn't compress at all. And then if you don't want your provisionals to fall off, ViSalus temp is just amazing. It's crazy retentive, and your temp is not falling off. So one more digitally planned case. So this patient presented with just wanting to restore her implant crown that she had done. And then partway through the whole thing, she talked to us about getting her smile back to what it was many, many years ago. And, you know, when your patient brings in a picture like this, then it's a whole nother story. It's not just single tooth dentistry at this point, especially when you start to look closer at the case. So here she is retracted, and then you can see that what brought her in was number 9. She didn't like how that looked, and it wasn't a very dated restoration. It was less than about 7 years old that she had this done. So 7 years before she came to my practice, she had this done. And it was restored with that edge kind of matching the wear on that whole left kind of upper left quadrant. And so this didn't wear over time. This was just how it was restored. So that was the length, that was the original length that it was made to. So she did, needless to say, she was unhappy with how this looked, and you can see the diastema there. And then our width to length proportions are just kind of off. The teeth are very bell-shaped and triangular. So this was a difficult case because when you're trying to be conservative and close spaces, it's hard when there's this type of shape to the teeth. It's hard to do a conservative prep and move that space around. So we had to do some case planning beforehand. So we start off with these Coyce digital reference glasses, and she has them on. And on the left picture, she's in a rest position where she's just saying Emma. And so this is where we look to see where that cuspid 0 position is. And we kind of take that measurement. We measure where that canine is and work our way across the incisal edges to see where we want the length of those new maxillary central incisors. The right side is more of her exaggerated smile. We're trying to analyze her lip mobility. So we send all of this information to the ceramist, of course, and we see that we have this little smile preview, but he starts to do our reference planes, and then we take a closer look at her rest position. We see that central incisor number 8 kind of peeking out here, and then the rest of the maxillary anterior just kind of disappears. It's not there. So we know that we have room to add on. I'm going to just stop for a second. It looks like there might be a couple of questions. Let's see if I could. Okay, so this question was, do you take a face bow for either digital or analog? One of my ceramists does not use a face bow at all. He basically just wants me to take a very straight headshot that has like the full like head to chin in a very kind of straight on way. And then the other is fine. Yes, you can do it. I have the Panadent, Coist Panadent face bow that I do like to use sometimes with these cases, especially if my reference planes are a little bit off. I definitely would like to use that. Now there's facial scanning software that takes a scan of the whole face, and all of that could change in the future. So the answer is yes, I do sometimes take a face bow. And then the second question was, can you suggest an analog wax up kit? How about we come back to that later at the end? But thank you so much for your questions. So let's come back to our case here. So here we are. This is the proposed wax up on the left. And then we see our married model or combined output model that has everything kind of put together. And then we can really see how bell-shaped these existing teeth are and how our wax up is changing things and improving our proportions to that 75 to 85% width to length ratio. So from there, again, we go through the little cross sections, and on this right side, you can see where she's got that facially flared kind of outline to her existing dentition, and then the proposed new wax up, we're pulling her in, and then we're lengthening. So we want to make sure that we're not constricting her bite, of course, and we are able to add about 1.5 millimeters to where she's at, especially on that upper left quadrant. So our wax up again, here on this canine, we can see where we're adding length and we're going to take away, but it's so good to have this, because if you are one to do a mock-up before prepping, then you know that you're going to prep from the outside of that proposed new kind of face of that restoration and then prep in, versus just taking the bird right to the tooth. Then we just get a couple different views. And so because of the spacing in this case, they asked us to break through the contacts so that they could wrap the restoration around in order to redistribute that space and close the diastemas. So the patient was well aware of this and did not want to do any type of orthodontics. And certainly we couldn't move that implant because it's where it is. So there was no, changing that orthodontically. And so here she is on the left before, and then here she is after. And there's our retracted view again, and just a huge difference. We recently did this case, so we weren't able to bring her back to do our glamour shots, but she's so much closer to where she was before, and she's thrilled because she looks much more like this historical photo. Digital workflow for chairside composite. Why don't we stop for a moment and throw up that third poll question? How are you doing it? Are you taking analog or digital impressions for your anterior cases when you have more than, I would say, 2 units? Okay, it looks like 66% of you are taking an analog impression for your multiple unit cases, and then 37% of you are doing digital. That's just, to me, fascinating, because everyone's kind of, in their own place with this. So my digital workflow for chairside composite veneers, which I do quite a bit of in my office, I again start with taking pictures. I'll scan the patient and then review their history, determine again if we're restoring what the patient lost, and if we can restore it in maximum intercuspal position, or are we deprogramming, equilibrating, and altering the existing occlusion. I sometimes do what's called a dental facial analysis, and I'll show you how that looks later. And then we'll 3D print the models. And then we'll go ahead from there and decide on what type of wax up we're going to do, whether it's analog or if we're doing a digital case. And sometimes I'll take the digital case and add on to that. So like wax up with wax or some type of a blockout material or flowable composite, and just do like a hybrid wax up if I want to tweak that digital wax up a little bit. But the end goal is to create a putty matrix to use as a stent to help develop my lingual contours. And then I build out the facial doing either freehand composite using matrices, or of course, injection molding is always an option. So when you're doing a digital wax up, some of you might be already doing this. You can outsource it for someone else to digitally design, or if you have access and or you've purchased a software that allows you to design your own, then certainly that's an option. So if you're outsourcing, there's many to choose from, but there's just a few here that I've outlined. Some of them are subscription services where you sign up for like kind of the full service, you plug everything in and they'll start designing the case for you. And then I use Evident. They have both a subscription and pay per case option where when I send in a case, I pay for that and just that. And then there's, of course, now I'm sure you've all heard of some of these really amazing software packages that are out there. Exocad, 3Shape by Dental Systems, Blender for Dental, Mesh Mixer. So going down from the top to bottom, if you are able to invest in kind of like a full service design software, Exocad is fantastic. It's just very popular out there, user friendly. And then Trios has Dental Systems that a lot of both my ceramists actually use for when they're designing cases. And then there's Blender for Dental, not a well-known option, but a lot less of an investment, and it's a great kind of learning software. And you know, if you can master this, then this can be your go-to. So that's something that I spend time working on and learning, and then hopefully one day invest in something bigger. But there's also free software, CAD design software, such as Mesh Mixer, that isn't specifically made for dental, but can be adapted and used for dental. So let's look at another case. So here, this patient presents in her early 20s, and she would like to change her smile. We start to take our photographs, collect our data, and we can see that she has a cant, kind of like tipping. You know, the canines really are what throw you off when you look at this, but also just some gingival asymmetry there that we see. And we can begin by just drawing on the pictures. So in the past, we would print out photos and just kind of draw on the pictures and say, this is where we could place these new restorations. And now you could take an iPad and draw on it with just an Apple Pencil, or, you know, Photoshop and use a liquify tool. But we go ahead and digitally scan her, and we have what's called an STL file of both her arches. And then I send that to Evident, and sometimes I'll do what's called a denofacial analysis, where I could just kind of look at all these measurements and have them right there for me. I could look at her, the length of her incisors at this point. The centrals are at 8.6 to 8.8 millimeters. So we've got room to lengthen those, because average for centrals are about 10.5 to 11 millimeters. So we know we can lengthen a bit there in the centrals. The canines are already quite long there. So anyhow, coming back to our case, Evident sends me a diagnostic wax up that's done digitally, and I want to tweak it a little bit. I asked them to modify a few areas there. And if I don't ask them, I'll go ahead and do it just after I digitally print this. I'll just kind of get a bird to it and shape it if I need to. And then they'll send me an Exocad web view, and I'll see if I can show you that at the end. But so this is a way to look at a case in Exocad, have them design it in Exocad, and then you just take a peek at it, and you're not actually doing the design in Exocad. You don't purchase the software. So it's kind of a nice way to get introduced to it. And then from there, we develop our treatment plan. So for her, we want to just kind of soft tissue recontour 7 through 10. We're not going to do osseous surgery on her. And she wants a really full, bright, white smile. So she would like to do chairside veneers from all the way from 4 all the way back to 14. So a lot of hands-on work, and of course an occlusal guard afterward. So we start with printing our 3D model, and then we've got putty material so that we use that to make our putty stent. And then I'll section that so that I'm able to do kind of like the stents that we saw up before to give us an idea of where the incisal edges should be. And then I start building that up, and we use that template as a guide. You can see we have Teflon tape on the adjacent teeth. Something that I like to use in between layers of composite when I do these chairside composite veneers is a flowable. Omnichroma makes a really nice flowable that has a chameleon effect that kind of takes on whatever its environment is, and it's got low shrinkage rates as well. It's great for shades between shades A1 to D4. So once I build up my lingual and palatal shelf, I'll put in the matrix to remove the stent, of course, and then start putting in my mylar strip. So we put a really thin layer of the Omnichroma Flow on. And then we'll take our micro hybrid or our micro fill and just kind of paddle that on afterward. And that flowable helps to bind the layers. Really nice to just have that in between there. So moving on, we start to build up all of the teeth, and then I go through and start polishing. Shofu makes a fantastic series of discs called the Super Snap discs. They come in 2 different sizes and 4 different grits. I like the dark coarse one to start to develop my outlines. They're single-sided so that I'm not nicking the adjacent tooth. And there's no metal hub, so then you don't have to worry about ditching or divoting the restoration. So once I start to do my primary and secondary anatomy, I'll do the elevations and depressions that I need to. And I like to use this one gloss point by Shofu to get in there and polish all of our depressions. So here's their kit. They've got the full Super Snap kit, and they make strips as well. And then the one gloss point comes in different shapes. So the point, the disc, and the cup. Then they also have a composite finishing kit that's really nice to get in there. So here she is, before on the left and after on the right. And she chose to have Tokuyama Estelite Omega BL1. It's probably one of their brightest shades, but that's how bright she wanted to be. And that was, for her, this was her dream smile. So she was thrilled with how that looked. Estelate Omega comes in various shades, and they've got a translucent and also dentin shades, enamel shades, and then a milky white shade. So there's just a wide range of what you can use. So again, my favorite part, our clinical photography, and we do our headshots, our close-up shots, and just have a lot of fun with it in the office once we're done. And there she is, our very happy patient. And there's our headshot again. We had the fan blowing at this point. So yes. So in my office, I do all of my portraits right in the waiting room. So we have a photography setup right there, which we can disassemble, of course, when we're not using it. I use just a portable backdrop, and I've got ProPhoto D1 monolight strobes that I use with some soft boxes. I like to use a beauty dish that just kind of softens the look along with the reflector. My camera for this particular shoot was a Sony A7 III mirrorless camera with a 24 to 70 millimeter lens. And we have this old fan that we sometimes take out to create movement in the patient's hair. So you can get something not as expensive as this. Certainly there's multiple options, but here's our, of course, our softbox, and then we've got an octabox here, and then there's just a series of reflectors. Let me stop for a moment. It looks like we've had a few more questions here. Do you mind sharing which software you use to do Photoshop and iPad? Yes, it's just, so it's just Adobe Photoshop. That's the actual software. So you can, if you have an Adobe subscription or account, it's just using Photoshop. And the next question, are you trying to get canine guidance or group function? When I restore anterior cases, I always aim to get canine guidance. Occlusion, of course, is a whole nother topic. All righty. So coming back, so here's our less expensive photography setup. Newer and Godox make some really nice kits that you can get if you don't already have one, and just kind of a really good thing to have for when you're doing these cases. Let's do our last poll question. I think we had one more question. Okay, so just kind of in summary, do you prefer a digital or analog wax up for multiple unit cases? Let's see where you are as an audience with that. 74% of you prefer an analog wax up, and 26% of you prefer a digital wax up. So really just a lot of us loving that wax. And I think that, that's terrific. So coming back to all of this, tying it all together. So can we still have the best of both? And it seems like you would agree that we just have a lot to choose from. We can select to do an actual analog impression. We could digitally scan. We could pour up the model old school like we always have been for many, many years. Or we can 3D print. We can wax with real wax, which we all seem to really love. And then there's also the option of digital wax up. And then certainly if you're at the place where you're able to do a full digital protocol where you're milling in your office, that's fantastic. There's no right or wrong in dentistry. It really is about what's best for you and what you think is going to prepare you best for doing a case. My personal decision tree for digital or analog, it starts with determining how soon I need it. Do I need it right away or not? Will I restore it in composite or ceramic? And then if it is ceramic or possibly injection molding, I want lab support for that. At the end of the day, we want, again, to have just a seamless transition from our wax up to our final restorations. So if I need it right away, there's one thing I do sometimes is just take a putty impression of what's there and then drill out right into the putty and kind of make my own template. So if I want to lengthen a tooth, I'll just cut that right out. And then, of course, other options are to scan, do a wax up with Blender, and then 3D print that. Or, of course, scan, print, wax on the model or block it out, and then do a stent from that. So here's a quick picture of if I were to take a putty stent and just cut right into that. So I cut out about 1 millimeter here to lengthen that tooth, and then use that as a stent to get that tooth to be longer in composite. You might already be doing this. So again, for composite case, if I'm waxing up myself, I like to do a lingual incisal wax up because I can use that as a template. It's fast and it's nice to have that that palatal incisal all built up prior to doing a chairside composite. And then if I'm going to try to do a digital wax up, I'll do it with Blender. If I'm going to outsource it, I'll send that off to Evident, and certainly there's plenty of others that you could use and then modify that as needed. If I'm doing a ceramic case, if it's additive, I like to do an analog wax up. I love my wax, and I'll send that off because 6 units is a lot to wax, but it's amazing if you can make the time for that. If it's a combination reductive case or subtractive case, I do want my lab to be involved with this. And if we're doing it digitally, I like it because I can see down to the tenths of a millimeter where I'm going to add and where I'm going to take away. So in summary, every case is very different, and it really depends on the individual case and what makes sense, both financially and just from an outcome. If I know that I'll do something more comfortably in an analog way, such as taking a PVS impression, I'll absolutely do that. But then, sometimes I feel that digital adds a whole nother dimension that changes my outlook, and I know that I might prep a little bit less aggressively if I have the information that I get from a digital wax up. So hopefully I haven't thoroughly confused you at this point. Let me just see if there's one more question. Please mention brand of wax. Okay. Let me see. I might have had a picture of it. I'm pretty sure that I have a slide with the picture. And let me close this out. So at the end of the day, you really should go at your own pace when it comes to all of this. And I'll just talk for a minute about what we see on social media. There's so much out there, and there's a lot of pressure on us to be perfect and get these cases Instagram perfect. And it's hard because we kind of, and I don't know if you do this, but I do this. I want to, I want my cases to look like that, and it can be a little bit overwhelming. And truly, it's not about where everyone else is. It's about where you are and how you're evolving, whether it's with digital technology or just in an analog way. It's great. We have a difficult profession, and it's all about making it right and easy for us. I want to thank you so much for joining me tonight. Please feel free to email me with more questions, and I'll see if I can flip back in the question and answer portion to the name of the wax that I use. I know that I have a whip mix waxer, and their presentation wax. It's like a white wax, so that's what I have right now. There's all sorts of them. There's different waxes. So I use a Yeti wax brush. It's fantastic. That's the one in the picture. So I'll try to show that to you. And then why don't we go ahead and do kind of a formal question and answer session for the last 10 minutes. Before I do that, and just take a minute to thank our, oh, here's my little Yoda slide. It really is about getting there and doing it. If you've never done it before, certainly just start. There's sometimes we feel overwhelmed by something new like digital, and we want to just stick with what we're used to, but sometimes the best way is just to go ahead and do it. Huge thank you to our sponsors again, Tokuyama, Shofu, and Kettenbach. They're products I've used for a very long time, and they work really well with my workflows. And thank you to Catapult for hosting. But just to show you this Exocad view that I get from Evident. So here's my pre-op, and then there's my digital wax up. It's kind of fun to play with this and to show patients how that looks before we start a case. But thank you all again very much for joining us tonight. I hope you enjoyed the presentation as much as I did putting it together.